Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a compilation video here consisting of a few patients that I've seen over the last few weeks. And this is patient 1, who's a 5-year-old toddler, and they presented with bilateral fully occluding earwax plugs. These plugs are quite firm at the core. They had been softened by the patient's parents by the use of some olive oil medical grade spray for a few days prior to attending, but it's still a bit tricky to remove because it's quite a substantial plug in comparison to the size of the patient's ear. As you can imagine, young children have smaller ear canals, and as they grow, they not only lengthen but they widen. So I'm really dilating the ear here, and just to kind of tease this through. And the tail end, you may have noticed there's quite a lot of keratin, and so we can see the patient's eardrum, but the eardrum is dull. There's no light reflex. It's inflamed, so there's vascularis, so increased blood supply. And upon assessing the mobility of the eardrum, there was minimal movement when we changed air pressure in the ear, and we played a sound. We call it tympanometry. It's a pressure test. And what we actually do with tympanometry, we ascertain how much sound is being received and entered through the eardrum and via the 3 bones, the ossicles, to the organ of hearing, by actually measuring how much amplified sound that we play into the ear bounces back off the eardrum. So this test, it contains a pressure transformer, if you like, so you can adjust pressure in the ear, and it then plays a tone, a 226 hertz tone, and this probe has also got an internal microphone. So we're playing this low frequency sound at various pressures, and the eardrum is most compliant when the air pressure behind the eardrum is equal to the air pressure in the atmosphere. So when we play this sound, the microphone inside the probe is trying to detect how much sound is being bounced back off the eardrum, and then you can obviously subtract that away from how much sound that was initially played into the ear, and then you can calculate not only how much sound was absorbed by the eardrum, which is what we want, but also how much sound was emitted back out. And we do that at various frequent pressures, so we can then also decipher the middle ear pressure, because as I mentioned, the eardrum should be absorbing most sound when the air pressure behind the eardrum is equal to the air pressure in the atmosphere. So that's when the eardrum is most mobile. So if most sound is being absorbed by the eardrum and therefore less sound is being reflected back out at a negative pressure, we then know that this patient's got negative middle ear pressure. So they're very likely to have a blocked eustachian tube, which is the orifice that connects the middle ear, so the cavity behind the eardrum, to the back of the nose, the nasopharynx, and it regulates the air pressure. It's typically closed at normal resting state, but during the course of the day, without us even realizing, when we swallow, yawn, or chew, muscles either side of the eustachian tube where it connects to the back of the nose, they contract, causing the eustachian tube to momentarily open, which then allows the air pressure to equalize and any fluid accumulation behind the eardrum to drain out. And what we can also measure, if the sound that's being reflected back off the eardrum, it's this constant level across the entire range of pressures that we play, then we know the eardrum is not vibrating. So we can be pretty sure in our diagnosis the patient's also got fluid glue ear, which is what that first patient had. So we have referred them to their GP, recommended that they weren't in any pain. Sometimes they can, cases of glue ear in children, they normally experience nocturnal otalgia, so pain at night. And the reason for that is when you lay horizontal, especially at night with our circadian rhythms, you get increased dilation of the blood vessels at the back of the nose, which further blocks the eustachian tube. So further blocking the eustachian tube creates more pressure, and obviously you've got fluid behind there. It's going to compress that. So if you're a parent and you have a child and they experience a lot of pain at night, and they're kind of pointing towards their ears, then you can be pretty sure they've got glue ear. So do visit the GP. So the plan of action with glue ear is normally a watch and wait philosophy. Antibiotics are not always effective. You can give topical painkillers. Now, people ask, well, if the infection's behind the eardrum, why give topical painkillers? Well, that's because the eardrum itself is also becomes painful because you've got this fluid compressing behind the eardrum. And even applying some topical painkillers, so some lidocaine drops, for example, which then can make contact with the eardrum, kind of numbs the eardrum. So if it numbs the eardrum, of course, there's going to be less pain. And typically hoping for the child's glue ear to self-resolve. So the glue ear occurs if the eustachian tube is blocked, there's no air behind the eardrum. All the remaining air gets absorbed by the middle ear cells, so the mucosal cells that lines the middle ear. And that in turn forces fluid within the cells out into the middle ear cleft. Under normal circumstances, this fluid will drain, but of course, when you've got a blocked eustachian tube, it's just going to build up. And once it builds up, it's like you're underwater, sort of air behind the eardrum, you've got fluid, so the eardrum's not going to vibrate as much. And in some circumstances, there can be too much accumulation of fluid behind the eardrum, so it perforates the eardrum. It's like a water balloon, only so much water it can take before it bursts. Nasal drops can sometimes help if there's congestion, if that's the cause, congestion. And there's, in the UK, there's various kind of devices that you can blow into to help inflate the eustachian tube. So in the UK, we've got the Otovent nasal balloon, the ear popper device. So these are things that may help. Of course, a child may be too young to be able to use this. So patient 2 and 3, pretty straightforward, just including wax. We'll just put some olive oil spray in there just to loosen that. And so these kind of shorter videos here, I've got quite a few of these, so and I know a lot of people enjoy the compilation ones, so I'm just grouping them together. I've had some really long videos of late, as you've probably seen. So guys, I've got some good news. For the last, I've lost track of time, but I've applied for a patent for the WAXscope, which is the new device, it's all but ready. We're just actually waiting on some guidelines with regards to training, which are going to be released by some professional bodies. So of course we want to kind of make our training in line with that. I think our training may possibly exceed that. I'm not sure, especially the theoretical part, because I'm really spending a lot of time developing the theoretical component, and it's really going well. So yeah, this patent, I didn't realise how difficult it is to get a patent. When you get the examiner coming back with the reports, of course they're not specialists in the field, so they give you other prior art. So prior art is previous patents, and they try to state the claim that there's some similarities there. And then it's our job, and obviously the team that I worked with who helped me facilitate getting the patent, to sit down and read through all these patents. And I actually quite enjoyed it. Some of these patents are like 30-40 pages, and you just got to dissect it. And in the end, you realise, well, no, that prior art is completely irrelevant. It's nothing like the WAXscope. And this is the normal process, apparently, and it's quite time-consuming. And we just got notification today that the patent is to be granted. So that's fantastic news. I've got one more patent pending. It's for a suction probe that I'm developing. So I'll keep you guys updated. So last patient here, we just used some drops again, a dark plug of wax, managed to wriggle it out. Well, I hope you're all keeping well, guys. Take care, keep well, and speak soon. Bye.